Well, thank you for the introduction, Mehdi, and thank you for allowing me to be part of this excellent session. And I fear I don't have too much to add to what already's been said about many of these reentry devices. They do play a role, but as Dr. Varco mentioned, I don't use these real routinely in my practice, but I hopefully will show some potential advantages. I have no disclosures relevant to the talk. So when doing CTOs, I think many of these points have been made. Occlusions greater than 3 months are those we're going to be working with. And these are very common that we encounter in clinical practice, and over half of our patients with symptomatic PAD manifest these occlusions. The histopathology has been shown contributes to some of the challenges, but then some of the opportunities to successfully treat the lesion. And CTO success, I think, as has been mentioned already, really is predicated on skill, but more on strategy and being prepared for bailouts, as well as understanding your equipment. And there are many anatomic challenges with femoral popliteal CTO, particularly in the location of the CTO. On the left, we see an osteal lesion, which is very differently managed sometimes than those in the mid-SFA or distal into the popliteal segment. But certainly some things are true that visualization, proximal ambiguity can be an issue, distal ambiguity, calcification, crossing support, and true lumen status are important points when you're considering using these reentry devices. There are some risks with femoral popliteal CTO recanalization where these devices may help, including the ability to hopefully keep the lesion, the subintimal lesion from extending down into another segment. Perforation, embolization, or AV fistulae can also be issues. But really these CTO crossing devices and reentry devices, they certainly increase cost, but hopefully add to your effectiveness in ultimately crossing the lesion. We've talked a bit about the knuckled wire approach, which I think many operators start with. When that doesn't work, then balloon-assisted dissection reentry can be a helpful option. And this ultimately is an antegrade and retrograde wire, which are located in the subintimal space off of calcification, deflects those wires so they don't meet. And in that case, a retrograde balloon is inflated to create a channel for antegrade wire crossing through a distal cap and allows passage of your wire. And then the reverse CART is just the opposite of that, where you have an antegrade dilatation to facilitate retrograde wire passage through a proximal cap, and is a technique we use in our lab quite a bit. A parallel balloon technique, particularly for larger vessels, can be very helpful. Straight segments, large vessels, where 2 balloons are used to fenestrate the CTO and allow for passage of a wire, either antegrade or retrograde. This can be very helpful in those circumstances. There is an increased risk of vessel perforation, so you have to be aware of your vessel size and not oversize your balloons, especially if you have a calcified vessel. So when we talk about reentry devices, these are the 3 major ones that I've had experience with. The Outback is on the upper right corner. The Pioneer offers IVUS, and the Enteer catheter may have some cost advantages. And essentially, all these devices allow us, if you can't get into the true lumen with a Safari technique, to replace it with one of these devices and ultimately allow passage of your wire without extending your dissection. So specifically about the Outback Elite device, it's a 6 French compatible device that uses an 014 guide wire compatible lumen, 120 centimeter working length with a 22 gauge reentry needle and an LTD reentry process. So that process allows the operator to bring the catheter down beyond the occlusion into the area of true lumen. You rotate the catheter to form an L, then rotate the table or rotate the camera 90 degrees to tune it over the artery, and then deploy the needle. Some issues with this particular catheter is sometimes it does require you to balloon the subintimal tract in order to allow the passage of the catheter. Sometimes the needle is deployed, but the wire doesn't come out, and often it's just a manipulation issue with the needle can sometimes extend all the way through the artery. You just have to be aware of that. The Pioneer Plus reentry catheter is also 6 French compatible and works over an 014 guide wire, again 120 centimeter working length with a 24 gauge reentry needle. This catheter, in addition to offering IVUS capabilities, also allows you to objectively deploy the needle to various depths, which can be helpful depending on your vessel size you're working on. But the real advantage of this catheter is it does allow IVUS for guiding your reentry location. The Enteer reentry system is 5 French compatible, so there might be some advantages there, particularly when passing retrograde. It offers 2 working lengths, one for above the knee and one for below the knee. There's a 28-degree Enteer guide wire that comes with the catheter system that has a 28-degree deflection at the tip to allow it to pass through the 2 markers down in the bottom right to allow true lumen reentry. And when inflated, the flat shape of the balloon tends to orient itself to the true lumen. So just some final considerations, angioplasty in the subintimal space to pass any of these catheters is sometimes needed. Distal cap calcification can limit the ability to cross with the Outback catheter, as well as puncturing the vessel. Ultrasound-assisted techniques may offer safety advantages, particularly in more proximal aortoiliac recanalizations, and I think there's important advantages to that. Just to again mention XLPAD, which used studied a wire catheter approach versus a CTO crossing device primary approach. Folks that ended up with a wire catheter approach, most folks had primary technical success, although subintimal reentry was required in both arms of this study. Essentially, the need for subintimal reentry was not different whether you approached chronic total occlusions with a primary wire catheter approach or a crossing device approach. There was lower primary technical success with a primary wire catheter approach, but similar need for reentry and no difference in procedural success. And I think the takeaways from this study from XLPAD was that there were higher procedural costs with these reentry devices and CTO devices in general, with improved technical success, and the most cost advantageous strategy was provisional use of these devices, which can be helpful in significantly lowering costs than a primary CTO device strategy. So in my practice, I think the pedal axis has been extensively described here is really the approach I tend to take before reaching for these devices. It's commonly available, safe, effective, and efficient, and I think to the points that have been made earlier, these devices do play a role, but I think having that bailout strategy is really important. Retrograde crossing, I think for all the reasons, I won't go through these, but for all the reasons that we've previously discussed with tibial-pedal axis can be helpful, and again, I think that's my primary approach. To conclude, CTOs are common, add procedural time and cost. Pedal axis and retrograde crossing is safe and effective. These reentry devices can augment when those techniques are not useful in crossing, but an adaptive algorithmic approach, as Dr. Banerjee showed us, improves efficiency and maximizes success. Thank you.